In multiple myeloma, we have seen a revolution in the last 10 years with many novel drugs and novel combinations that have been approved and registered. Particularly, the revolution started with the Daratumumab, anti-CD38, that has been integrated as backbone in frontline setting in both transplant and not transplant eligible patients, particularly Dara-VTD versus Dara-RD and Dara-VMP. We are going to explore also new combination based on anti-CD38 in frontline transplant eligible setting. We have seen exciting results from the Perseus and Ischia trial with Dara-VRD and Isatuximab KRD. I think that the new endpoint will be not anymore the overall response rate, the progression-free survival, but the MRD negativity. We want to achieve the best, to achieve a deep and prolonged response, particularly in young and fit patients. So I think that we are going to change more and more the therapeutic panorama in frontline setting according to this data. In relapsed refractory setting, we are going to divide the patient according to their lenalidomide status, and particularly Lena refractory versus Lena sensitive. In Lena refractory, we have an excellent combination that is Isatuximab, Carfilzomib, Dexamethasone. Also in this case, thanks to the MRD negativity status, but also thanks to the data that are confirmed also in high-risk cytogenetic patient, which is a particularly important point. We have a novel opportunity that is possible to use also in my country, that is selinexor, bortezomib, dexamethasone, and I think that this is another incredible opportunity also thanks to the modality of administration, the compliance of the patient, and also the wonderful tolerability profile. I think that this is another incredible opportunity for second-line patient, and I think that we will explore exciting data also in our real-world setting in which we are going to explore this combination. In lenalidomide-sensitive patient, we know that the more solid data are of Pollux combination, Daratumumab, lenalidomide, dexamethasone, that has shown a never-seen progression-free survival. But I want also to underline that we will have a novel opportunity which will be able to use in both the possibilities, in both the categories of patient, which is Belantamab, Bortezomib, dexamethasone. We have seen incredible data thanks to DREAM7 clinical trials data. I am honored and proud that me and my institution have collaborated to those data and to the paper that is going to be presented. Belantamab, Bortezomib, dexamethasone has shown an incredible efficacy result, but also balanced with a wonderful tolerability result. If we anticipate Belantamab mafodotin, we don't see any life-threatening problem, we don't see any high-grade ocular problem, and I think that as every drug, if we go to anticipate in a patient that is in better condition, we can achieve the best response balanced with a very good efficacy result and with a tolerability that can be absolutely considered and can be absolutely balanced for our patient. In every pretreated patient, we are going to explore other combinations. We have other monoclonal antibodies such as elotuzumab that is going to be combined with pomalidomide and dexamethasone according to Eloquent 3 trial, but we are going also to see in our daily clinical practice bispecific antibodies. Teclistamab and elranatamab are the first approved and registered, and we are confirming their efficacy also in our non-selected real-world population. But I'm strongly looking forward to the introduction of CAR-T in our real-world setting. They have been in potential use also in my country, so I think in this moment we need really to establish which is the correct sequencing also between the ultra-novel agents that we are going to use. And I don't want to forget that we have also other possibility to use in our patients. Someone are totally immunotherapy refractory. We can use a totally different mechanism of action, such as Melflufen, which is a new way of performing chemotherapy. I think that in the idea of the heterogeneity of this disease, we can understand which is refractory to immune agents and in which we maybe need to evaluate the potential chemosensitivity. And I think that compared to a good tolerability and to a good schedule, Melflufen can be used in every pretreated patient in the idea of totally changing the mechanism of action. All these novelties balanced with the many clinical trials that are exploring new bispecific antibodies, new targets such as talquetamab, that is a new bispecific antibodies with different targets, new CAR-T, also going to academic CAR-T, but I think that we need to understand what we have currently in our hands, and we have to consider that thanks to these agents we we are going to totally revolution the outcome of our patient, and that we are running more and more to the cure of multiple myeloma. And this is the best wish for our patients, their caregivers, and for all the myeloma researchers in the world. Thank you for your attention.